Normal tension glaucoma. So what is normal tension glaucoma? Let's take a couple of seconds to briefly discuss intraocular pressure first, which will then give us some foundation to understanding this disease. Intraocular pressure is the pressure created by fluid within the eye. And one of the main functions of intraocular pressure is to maintain the eye's shape by exerting that fluid pressure inside the eye. It is also important to note that intraocular pressure is being exerted in all directions within the eye. So normal intraocular pressure is accepted to range from 10 to 21 millimeters of mercury. Glaucoma subjects having an IOP consistently higher than 21 millimeters are classified as having high tension glaucoma. Glaucoma subjects having an IOP consistently within a normal range are classified as having normal tension glaucoma. High tension and normal tension glaucoma. Is HTG and NTG the same disease? Yes, I believe they are the same disease. Both high tension and normal tension glaucoma subjects have similar glaucomatous optic disc changes, similar visual field effects, and run the same course of disease. Some researchers believe that since IOP and NTG is consistently within the normal range, that non-IOP factors such as lack of perfusion to the optic disc may be involved in the development of NTG. Some researchers also believe that NTG subjects have an unduly sensitive optic disc to IOP. However, if this was true, then the NTG subjects should have developed glaucoma in early childhood and not later in life. Glaucoma is definitively a multifactorial disease. However, the main risk factor in glaucoma is elevated IOP in HTG and normal IOP, which is acting as elevated IOP in NTG. Only elevated IOP has been established as a sole risk factor in the development of glaucoma. For example, in unilateral traumatic glaucoma in a healthy young adult, the only risk factor is moderately elevated IOP. This confirms that even moderately elevated IOP acting alone can result in glaucoma. Other risk factors such as high myopia, chronic hypotension, sleep apnea, long-term smoking, and Raynaud's disease have been commonly implicated in the development of NTG. Therefore, elevated IOP is a primary risk factor, while others may be called secondary risk factors. However, no risk factor other than elevated IOP has been identified as a sole cause of glaucoma. There are at least 4 established facts in normal tension glaucoma. Number 1, NTG progression being slowed by further lowering of normal range IOP suggests that even normal IOP is involved in NTG. Number 2, NTG being more common in COPD, sleep apnea, and long-term smoking suggests that poor oxygen saturation to the optic disc may be involved. Number 3, NTG being more common in cases of chronic hypotension and Raynaud's disease suggests poor circulatory conditions to the optic disc. And number 4, NTG being more common in high myopic subjects suggests that inherent weakness of the scleral opening may be involved in high myopia. So one of the most important concepts in glaucoma is the orderly loss of the nerve fibers. The most salient feature of glaucoma is the orderly peripheral central loss of nerve fibers in both HTG and NTG. It is the basis for performing perimetry in glaucoma. As you can see in the schematic diagram, the early stages begin with isolated scotomas, which eventually coalesce to form a double arcuate ring. At the same time, you have peripheral field constriction, which eventually joins with the ring scotoma, and only the central vision remains. However, the central vision is also lost in the end stage, resulting in total blindness. It is important to note that it is inconceivable that elevated IOP or any other risk factor, by its direct action, would selectively destroy the nerve fibers in this orderly sequence. So this raises a puzzling question. How is elevated IOP leading to the orderly loss of nerve fibers in glaucoma? Well, the answer may lie in that only a mechanical process can result in the orderly loss of nerve fibers. Another question arises as to how is elevated IOP leading to that mechanical process? It appears that elevated IOP must be destroying some important component of the optic disc first, which would then lead to that mechanical process. Lastly, what may be that important component of the optic disc? Well, this important component must be a primary site of injury in both ATG and NTG. So what may be that primary site of injury in both ATG and NTG? Can the lamina cribrosa be the primary site of injury in glaucoma? It is unlikely. Glaucoma's field effects are horizontally oriented and correspond fully to the horizontal arrangement of nerve fibers in the retina until they make their 90-degree turn into the optic disc. Therefore, the primary site of injury to the nerve fibers in glaucoma should be either prior to or at their 90-degree turn and not afterwards. After their 90-degree turn, the nerve fibers become vertically oriented in the lamina cribrosa. Therefore, the lamina cribrosa can't be the primary site of injury as it couldn't produce the horizontally oriented glaucomatous field effects. How about the border tissue of Elschnig? Can this tissue be the primary site of injury? Most likely. The border tissue is the collagenous tissue which keeps the lamina cribrosa firmly in place like an O-ring seal. We can see that here on the right shown in green, in which the border tissue lies between the scleral edge and the lamina cribrosa, holding that lamina cribrosa firmly in place. If the border tissue becomes degenerated, the lamina cribrosa would become loose and start sinking in the scleral canal. This mechanical process would then lead to the orderly loss of nerve fibers in glaucoma, as we'll discuss a little later in this presentation. Before we discuss the degeneration of the border tissue of Elschnig, it is imperative to discuss its blood supply. The eyeball has a dual blood supply, the central retinal artery and the ciliary circulation. The ciliary circulation supplying the border tissue is of lower pressure, around 25 millimeters of mercury, whereas the CRA is of higher pressure, around 60 millimeters. The border tissue is solely supplied by the low pressure ciliary circulation through the circle of inhaler. Unfortunately, the border tissue does not receive any contribution from the high pressure CRA. As you can see in the schematic diagram here, the border tissue is solely supplied by the ciliary circulation. Let's discuss the interaction between IOP and the circulation of the border tissue. The ciliary circulation supplying the border tissue and IOP are opposing forces. Normally, the circulatory pressure of the border tissue, around 25 millimeters, is higher than 21, the upper limit of normal range IOP, for the proper perfusion and healthy maintenance of the border tissue. What would happen if this delicate balance is reversed? Well, if IOP becomes higher than the circulatory pressure, it would start compressing the border tissue circulation, resulting in chronic ischemia and a degeneration. For example, if the IOP reaches 30 millimeters of mercury, it would start compressing the border tissue circulation of 25 millimeters, resulting in ATG. We can see this on the right in the schematic diagram in column B, which shows the IOP at 30, which is higher than the ciliary pressure at 25. Conversely, if the circulatory pressure of the border tissue is reduced to, say, 15 millimeters of mercury, such as in cases of chronic hypotension, then even a normal IOP of 20 millimeters will act as elevated IOP and start compressing the border tissue circulation, resulting in its degeneration. This would be an example of NTG. We can see this on column C on the right, in which the IOP at 20 millimeters is still higher than the circulatory pressure. Reduced circulatory conditions of the border tissue in NTG would be further worsened by at least two additional risk factors. First, the structural integrity of the border tissue. For example, high myope subjects have a thinner border tissue due to a bigger scleral opening, would be more prone to border tissue degeneration. Second, the systemic oxygen saturation of the border tissue. For example, subjects with reduced systemic oxygen saturation in cases such as sleep apnea, COPD, and long-term smokers will be more prone to border tissue degeneration. Glaucoma is truly a multifactorial disease. However, elevated IOP in HTG and normal IOP acting as elevated IOP in NTG is the main cause of both glaucomas. Secondary risk factors such as high myopia, chronic hypotension, Raynaud's disease, COPD, and long-term smoking will contribute to the rapid degeneration of the border tissue in both HTG and NTG. The more risk factors present in HTG and NTG, the more the likelihood of the early development and rapid progression of both types of glaucomas. So what is the course of both HTG and NTG? Well, once the border tissue becomes degenerated and the lamina cribrosa becomes loose, the lamina cribrosa will start sinking in the scleral canal. As the lamina cribrosa sinks, the most peripheral nerve fibers being situated deepest and closest to the scleral opening will be stretched and severed first against the scleral edge. As more of the nerve fibers are severed and depleted, the lamina cribrosa will sink further due to the loss of anchorage provided by the nerve fibers, as roots provide anchorage to a tree. This cascade of the sinking lamina cribrosa and severance of nerve fibers would become self-propagated and continue until the most central nerve fiber has moved to the scleral edge and gets severed. The histology of the end-stage glaucomatous disc reveals an empty crater totally devoid of nerve fibers, a tragic ending to a healthy optic disc which started with the loosening and detachment of the lamina cribrosa. Please like and subscribe if you'd like to see more content. Thank you.